I'd like to welcome you to this session of the Center for Podiatric Education. And in this session, I'd like to discuss a topic that I find important to discuss, and that's the question of what is a complication. Oftentimes, patients who are dissatisfied with their care seek the evaluation and treatment of subsequent treating physicians who may use terms that are perhaps inappropriate in describing the status of the patient's foot or ankle surgery or treatment, perhaps non-surgical. And oftentimes incorrect wording can result in patients going to attorneys alleging malpractice. And I would never suggest that any provider ever engage in a willful cover-up, if you will, or utilize inappropriate terms. However, we do want to be careful with certain words that we utilize. So what is a complication? Well, complications are great for watches. When you purchase an expensive watch, they'll oftentimes talk about the number of complications associated with that watch. But using the term complications sometimes does just that. It complicates matters. So what is a complication? By definition, and I think this is the best definition I've seen, a complication is any undesirable, unintended, and direct result of a surgery which would not have occurred if that surgery has gone as well as would have been anticipated or hoped for. So it is something that occurred that was undesirable, it was not intended, and directly resulted from that surgery. That is a complication. If we look at evaluation systems for surgical procedures, such as the American College of Foot and Ankle Surgeons or the American Orthopedic Foot and Ankle Society, and we say, I'm thinking about doing a particular procedure, let me see how the results of that procedure have been reported. Generally, you see that the evaluations revolve around function, some measure of the overall health of the patient, some quality of life measure, and various evaluations of patient activities. But we generally don't have evaluations of the complications. And there's no standard that exists for reporting complication rates. And so we really don't always have an understanding as to potential problems that can arise with any particular procedure. So we'll read an article and it'll say that this many people had an infection, or this many people had a non-union, or this many people had a malunion. But the impact of those complications on those patients is ungraded, and we don't recognize that some of these can be very impactful. So why be concerned? And the answer is because not all complications are equal. For example, as you'd imagine, a non-union following an ankle joint fusion or a subtalar joint fusion may have tremendous impact compared to, say, a non-union of a second toe arthrodesis, which was otherwise non-painful, non-swollen. We just had a radiographic non-union. Nerve injuries, we may have someone who has some numbness following, say, a bunion procedure, but it doesn't interfere with their function or activity level, versus a patient that has a nerve injury and develops complex regional pain syndrome. We have differences in vascular injuries. We have patients who may have a blue toe for several hours following surgery, or perhaps a chronic edema versus gangrene and a need for amputation. Malalignments, we may have a floating toe following a lesser metatarsal osteotomy versus a malunion with an elevated first ray and sesamoid pain following a first MPJ fusion. As an example, look at non-unions reported after the Lapidus procedure. While we know that as many as 1 in 8 patients following a Lapidus procedure may develop a non-union, we also know that the majority of non-unions following a Lapidus procedure are not symptomatic, or they are minimally symptomatic. So the patient may have some slight swelling, they may have some slight discomfort, but oftentimes the non-unions following a Lapidus procedure really are minimally symptomatic. Similarly, first MPJ fusions, the literature shows that the majority of first MPJ non-unions may be radiographically present but are minimally symptomatic to the patient. In describing our own surgeries or describing the evaluation of the work of other people, it's important, I think, to use proper terminology. And this can also be extrapolated to non-operative therapies. So we have surgical complications, which are undesired and unintended outcomes that would not have occurred. We have failure of treatment. Sometimes patients just don't respond appropriately to appropriate care. It may have been the correct antibiotic and they simply did not respond. It may be an appropriate anti-inflammatory. It may be a surgery that was properly done, properly selected, well performed, but the procedure failed to obtain the correction that was desired. So we call this failure to cure. And we know that even the best of you listening to this out there right now do have patients on whom you've probably selected a procedure appropriately, performed that procedure appropriately, and yet failed to effect a cure in that patient. We have operative sequela. Things can happen after any surgery that are known to occur in association with that surgery. And then we have surgical error, and we have negligence and malpractice. So here's an example of a patient who had a subtalar joint arthroeresis done, and the patient extruded the implant following surgery. Now, is that a complication? Is that just failure to cure and a poor outcome? So we can argue that perhaps the implant wasn't placed properly. However, we all know that even with properly performed subtalar joint arthroereses, displacement and extrusion can occur. On the other hand, what about a case like this? So this is a juvenile patient who had an implant, a subtalar joint implant placed in his foot. The doctor had never utilized this particular implant before, and unfortunately the rep for the company was not available the day this procedure was done. The rep went out of his way to notify the doctor that he would not be available. He left guidelines and instructions for the use of the implant at the doctor's office and left them in the operating room for the doctor. This was a set with which this particular doctor was not familiar. The doctor utilized the implant, and the trial implant in this case had cutting threads. As you can see, the implant was placed through the posterior aspect of the foot, through the neck of the talus and out the medial side. It wrapped up the posterior tibial tendon. It created an injury to the undersurface of the talus. And it turned out that the implant was actually the trial prosthesis, and this particular implant has instructions with a black box warning that state you never implant the trial prosthesis because it has cutting threads. The representative for the company making this implant showed up the next day, collected his equipment, and had mentioned to the OR staff that he saw that they did not use any implants because all the implants were still in his box. They said, oh no, The doctor definitely implanted one, and they came to realize that it was the trial prosthesis that was implanted. This became more complicated when the doctor, rather than acknowledging the error to the parents, waited a bit of time, took an x-ray, implied that the implant had dislocated and required removal. Unfortunately, the parents had already been notified by the company manufacturing the implant that the implant was in fact a trial with cutting threads and required immediate removal. The parents went to a pediatric orthopedic surgeon who told the parents what happened, and it resulted in litigation. And you're looking at the immediate post-operative films. Now, by the way, just to show you that things are what they are in this world, they were actually able to find a quote, expert, close quote, who was willing to testify under oath, and did in fact testify under oath that this implant was in an acceptable position. Anyway, my question is this: given everything I just told you, would you regard this as a complication? Or would you regard this as negligence or a mistake? Or would you regard this as malpractice? So we have this concept of failure to cure, and that's the failure of a procedure to provide the desired outcome, and that is not in itself a complication. And procedure failure is not malpractice. For example, doing a cheilectomy on a great toe for hallux limitus and failing to get adequate post-operative range of motion or relief of pain. Is that a complication, or is that failure to cure? And I would argue that if the choice of a cheilectomy was reasonable, or the choice of a decompression osteotomy was reasonable, or the choice of any procedure was reasonable, and it simply failed to cure, failure to achieve the desired end result, that is not a complication and shouldn't be described that way. It was simply a failure to cure. The procedure was well chosen, well performed, but unfortunately failed to achieve the desired end result. How many times have we applied skin grafts or skin graft substitutes in an effort to heal a wound, and the wound fails to heal? That is not a complication. That is simply a failure to cure. We also have post-operative sequelae, and these are known, predictable, possible complications following a surgery. For example, a patient undergoes a double or triple arthrodesis for posterior tibial tendon dysfunction and develops arthritis in an adjacent joint. That is not a complication. That is a known sequela. Perhaps a better example is transfer metatarsalgia following bunionectomy with osteotomy. Now, assuming there's not, for example, excessive elevation or excessive shortening, we know that most first metatarsal osteotomies are associated with some decreased weight bearing by the first metatarsal and some increased weight bearing under the adjacent metatarsals. And this is a sequela. So we have complications, we have a failure to cure, we have post-operative sequela. So, where do we rate procedures? Well, sometimes that line is difficult. Here's a patient who developed transfer metatarsalgia under the third and fourth metatarsals following a bunion correction and a first metatarsal osteotomy. Now, on the one hand, some may look at this x-ray and say there's excessive shortening of that first metatarsal, malalignment of the second metatarsal, and the transfer metatarsalgia to 3 and 4 were predictable. However, if you were asked the question, is it possible to develop transfer metatarsalgia even with a well-performed first metatarsal osteotomy where there is not apparent excessive shortening? If you were honest, you'd have to say, yes, that can happen. Of course, a plaintiff's expert, a full-time professional plaintiff's expert might not be so quick to agree. And so the question becomes, how much shortening is acceptable? how much malalignment of the second metatarsal is acceptable. But we know that transfer metatarsal pain following a bunion is a known sequela. And then we have surgical error. Now, an error is, as you know, a mistake. And under certain circumstances, errors can be associated with medical negligence. So the most common errors that we see in foot surgery are errors in technique. You may look at the work that you did or someone else did and feel that the technique was inappropriate. Oftentimes when there is failure to cure, there's an argument made that this was a judgment error. Perhaps the wrong procedure was performed. Sometimes errors occur because of inattention to detail, or there may have been a failure to make an appropriate diagnosis. So here again, we want to think about definitions. Is what we're looking at, whether it's our work or someone else's work, a complication? Is it a simply failure to cure? Is it a mistake? Is it error? Is it a sequela? So let's look at this particular case. This was a Lapidus procedure that was done, and it went on to a non-union. And I think most people looking at this X-ray would likely question the robustness, if you will, of the fixation utilized. So this patient went on to a painful non-union and required grafting and a revision surgery. So in hindsight, the question is, was this a complication? Because after all, we know that non-unions can occur absent any negligence. Is this a mistake? Is it negligence? And if one were to say, well, I am certain that the non-union was due to the fact that the patient had ineffective fixation, it was insufficient, and looking at the records, the patient was ambulated too quickly, then, the defense would be, well, but doctor, even under the best of circumstances, can't you still get a non-union? So where do you draw that line between causation of the non-union and the fact that this could have occurred under any circumstances? Sometimes we see cases such as this where some toe repairs and an osteotomy was performed of the third metatarsal. As you'd imagine, the third metatarsal went on to a non-union and there was transfer metatarsalgia. Is this a sequela of lesser metatarsal osteotomies? Because we know that lesser metatarsal osteotomies can result in transfer metatarsalgia. Is this a complication? Is this just failure to cure? Or is this negligence in the performance of this surgery? So how do we define the difference between a mistake and negligence in looking at our own work and the work of others? And generally, a mistake is something that is negligent only when a reasonably careful doctor would not have made the same mistake under the same or similar circumstances. So the mere commitment of a mistake, the mere committing of a mistake, is not in and of itself negligence, because there are situations where a reasonable doctor may have made the same mistake under similar circumstances. So what about something like this? A patient has a non-union of a subtalar joint fusion. CT scan shows that the threads of the fixation screw have not crossed the fusion site, and one could argue that that was the cause of the non-union in not allowing compression to occur. So again, we look at a case like this, and in hindsight, it's very easy to say this is negligence. But how many times have you taken x-rays in the operating room and thought you had adequate fixation, and because it's difficult to perfectly position the foot at times in the operating room, to be surprised on subsequent in-office x-rays that the fixation was not quite what you thought it would be? Or would you say, look, everything should have been done to ensure proper positioning of the screw threads, and this is negligence? How about a case like this? This was a patient who had a fusion of the second toe PIPJ. There was a malunion of the toe and overlapping of the toe. The patient, in addition, as you can see, had swelling and a malunion, and this required surprisingly extensive revision, given the fact that it was just a toe, but it was extremely painful to this patient. So again, the question becomes, we have a non-union, we have a malunion, we have painful hardware, we have persistent swelling. Is this a complication? Is it a known potential sequela? Is it negligence? Is it a mistake? Is it malpractice? What about a case like this where a patient is left with this as the post-operative x-ray? Is this a mistake? Is this negligence? Is this failure to cure? After all, one could say, well, doctor, have you ever operated on hammer toes that have reoccurred? And so why do you think that in this particular case the reoccurrence was due to less than adequately performed surgery? Here's a case where a doctor had hired a young associate to do surgery for him. And the patient and the doctor were at the surgery center. The young doctor called in sick. The older doctor said, I've seen enough of these. I think I could do this myself. And he did an Austin bunionectomy and inadvertently cut entirely through the second metatarsal. No intraoperative x-rays were taken, and this was not recognized until the patient made it back to the office, and this was the first post-op x-ray in the office. So here again, would you consider this to be a complication, a sequela, a failure to cure, or would you consider this to be negligence? The patient was taken back and the deformity was reduced in a subsequent surgery. What about a case such as this? This was a triple arthrodesis that was performed by someone, and the patient actually left the operating room with these x-rays on the lateral view. Obviously, the patient developed problems with the ankle joint, problems in the plantar surface of the heel, and required revision surgery. So again, would you consider this to be a complication, a sequela, a failure to cure, or would you consider this to be negligence for failing to recognize the extent of malpositioning of the hardware? We do want to have some type of classification system for complications. For example, 2 or more procedures may have the same complication rate, but they may not be equal in effect. So we want to know how bad a complication is that occurs after particular procedures. For example, looking at complications following total ankle arthroplasty versus arthrodesis. And this way, with this information, armed with this information, we can make perhaps better clinical decisions. Again, here's an example. We know that the majority of first MPJ fusions are, when they're non-unions, are not symptomatic, and the majority of non-unions of the great toe joint have symptoms that resolve when hardware is removed and don't require an extensive revision. In general surgery and gastroenterology and urology and orthopedics and nephrology, there is a system in place for classifying the extent of complications. So I've modified that complication and named it after myself and my wonderful former Yorkshire Terrier, Babette. And not to be flip about this, but really When we talk about complications, we need to have a grading system in evaluating these things to make proper reference to them. So just throwing this out there for everyone to consider. So we have grade 1 complications. So these are complications that involve a deviation from normal postoperative care, but no additional medical therapies required, no physical therapies required, no surgical interventions are required, and the complications really do not mandate any type of treatment and have no significant clinical relevance. For example, minor swelling after a digital arthroplasty or after a, say, a bunion procedure, a hypertrophic scar that's not painful and not associated with nerve entrapment, a patient who has limited range of motion following a bunion procedure but has no symptomatology. So these are grade 1 complications. They're not associated with the need for any therapy. Grade 2 complications require either additional medical or physical therapies for treatment. For example, a patient who has surgery done that requires some non-opioid analgesics, perhaps some anti-inflammatory medications. A patient who develops a cellulitis or postoperative infection and requires antibiotic therapy, either orally or IV, but has no residual long-term sequela. Or, for example, transfer metatarsalgia following a bunion to the second or third metatarsal, and the symptoms resolve with the use of orthotics. So these would be complications, yes, but they're a lower level of complication, or grade 2. Grade 3 complications are deviations that require surgical intervention. For example, an infection requiring incision and drainage, an osteotomy requiring revision surgery or bone grafting, and revision surgeries that require either local anesthesia or general anesthesia. So these are procedures that do require additional surgery. Grade 4 complications are complications which are limb threatening. So this could be, for example, a necrotizing infection. It could be a compartment syndrome. It could be acute vascular compromise. Grade 5 complications are complications that are threatening to the quality of life. For example, complex regional pain syndrome, or significant loss of limb length following the need to extirpate a total ankle replacement and eventually undergo a revision. Grade 6 complications would be complications which are life-threatening, such as DVT with a pulmonary embolism or a malignant hyperthermia or acute organ failure. So instead of just putting in articles that we had a complication rate of 6% or 8% or 7%, it would be nice to have a grading system so that we know the extent of the complications that occurred, because this will help us in our decision making as to whether to pursue those surgical procedures or not. In looking at complications that occur after surgical procedures, we often know that there are contributing factors involved, and it is important to note the presence of these potential contributing factors prior to surgery, and taking the time to offer appropriate interventions before proceeding with those surgeries in order to minimize those risks. For example, recommending the interdiction of smoking, discontinuation of alcohol use, perhaps weight loss before undergoing a major hindfoot arthrodesis. This type of therapeutic consideration ought to be considered. There are some procedures, I think, that are very much associated with a higher risk of complications. I think the older you get, the more you become more selective in the procedures that you wish to do for people. I think when it comes to Morton's neuromas, plantar fibromatosis, plantar fasciitis surgery, retrocalcaneal anything, tarsal tunnels, Charcot joint reconstructions, lesser metatarsal surgery, using biologics and orthobiologics or any type of unproven technology. I think you want to have a stronger base of non-operative care, try to get as many people well without surgery. I think you want to have a more compelling reason to do surgery, and I think patients need to understand clearly increased risk for complications in these patients. You want to remember with the new ICD-10 coding system, there are specific codes that are frequently utilized, including pain due to implants or other complications associated with implants. This can include initial presentation for that complication or subsequent presentation and sequela. Similarly, with fractures, you want to remember that you have coding separately involved for initial presentation with that fracture, and separate coding for evaluation for delayed union, for non-union, and for malunion or for sequela of that fracture. Complications including soft tissue and bone healing complications, wound dehiscence and disruption have separate ICD-10 codes, and you want to familiarize yourself with the various ICD-10 codes that are available to describe the complications that can occur. There are also separate codes available to describe complications with the use of grafts and graft-like materials. And similarly, there are ICD-10 codes for post-operative infections, both superficial and deep. So in summary, complications do not in and of themselves suggest that less than optimal care was administered. You want to remember the definition of a complication. You want to remember that failure to cure or procedure failure is not a complication, nor is it negligence in many cases. You want to understand that there are known and accepted sequelae to many procedures, and that, again, a known sequela is not necessarily a complication nor necessarily a suggestion of negligence or malpractice. And that we do want to have some type of coding system available in order to quantify the extent and seriousness of complications that do occur following the various procedures, so that we can help make better judgments as to whether or not we wish to pursue particular procedures in different patients. Thank you for listening.